Oh, welcome everybody. So we have a full house, which is fantastic. So I'm Matthew Cavanaugh of the Department of Global Health and the director of the Center for Global Health Policy and Politics. And we are thrilled to be here hosting Dr. Tlalang Mafokeng. Dr. Mafokeng, or Dr. T, as she is well known, is a medical doctor, a OBGYN, an activist in South Africa, an inspiring broadcaster and author. For those of you who are in the room who grew up in the United States at times that were in the past, she is, I often say, in many ways, the Dr. Ruth of South Africa. So if you don't know what that means, Google it, students. But she has brought kind of understandings of sex and gender and power into conversations around medical care for years. And in a brilliant stroke by the United Nations, which often does things that don't make a whole lot of sense, but sometimes do things that do make a lot of sense, she was named by the United Nations Human Rights Council as the Special Rapporteur on the Right to Health, the expanded name being, I'm going to try to get this right, the Special Rapporteur on the Right of Everyone to the Enjoyment of the Highest Attainable Standard of Physical and Mental Health. Is that it?
Oh, yes, very long.
Thank you. And she is right now in the middle of almost all of the political fights that are happening globally on health. And so in part, this event is in part linked to the class, Pandemics and Politics. And so welcome students who are here for that. And it is also the second, what I hope will become an annual lecture by Dr. T here at Georgetown. And what she's going to talk about here is this intersection of pandemics and politics and what she's seeing from where she sits at this moment of global crisis, of global inequality, of global disruption. What does that mean for somebody whose task is to ensure a very long, complicated set of words that mean, does everyone have the right to health? And so with that, please welcome Dr. Mafokeng to Georgetown.
Thank you.
She's going to speak a little bit, and then she and I are going to have a conversation, and then we will open it up to all of you, and then at the very end there are snacks, so don't run away. Okay,
We love
over
snacks.
to you, Dr. T.
Thank you very much. Good afternoon, yes, yes, to all of you, and thank you very much, Dr. Cavanaugh, for inviting me to share space with your class today. It's always exciting for me because I see myself as a perpetual student, so I wish I was also on the other side, having to listen and to share and co-learn with all of you. And I'm not a protocol person, and I know there's many important people in this room, but Ambassador Colter just wanted to say welcome and thank you as well for being part of this session today. Again, like Matt said, look him up, very important work. As a South African at the time, of course, growing up in South Africa, we had HIV as our crisis in that moment. And I was a young person at the time who was also just discovering themselves, discovering about relationships, about one's body, about sexual health, consent, all of those things. And so by the time the COVID-19 pandemic happened, some of us had already lessons and stories and experiences that we kind of knew how this was going to play out. For millions of people around the world, we know that the enjoyment of the full realization of the right to health remains a distant goal. And in many cases, this goal is becoming even harder to reach. And this is true, especially for people in vulnerable situations. And I often call vulnerable situations and not vulnerable people, because inherently being human is not a vulnerability. There's conditions that exist, there's a history, there's a context in which we live in every day that makes us therefore experience vulnerability in a certain way. And this is true for migrant people, minority communities, people with disabilities, people of African descent, LGBTQA+ persons who use drugs. And so we know that the realization of the right to health is impeded by many factors. And if you look around the world, it's not so much lack of funding or financing, but many of these factors, most of them are related to inequalities and selective approaches to human rights principles and consensus in the law, but also scientific evidence. We live in an era now where even science is being questioned fundamentally. But I want to bring something else to you in terms of vulnerability and vulnerable situations. And it's the ways in which stigmatization, criminalization, and discrimination are all public health issues. And they become heightened in the context of pandemics where there is scarcity of resources that's being created, or perhaps there was already fragile health systems before the crisis becomes a pandemic. And so we know how stigmatization, discrimination, as well as criminalization, therefore, causes poorer health outcomes for specific individuals and communities by further pushing these people to the margins. And so it's important, therefore, with that understanding, to come back to the definition of the right to health. Because then one would say, well, just make all the clinics available and open to everybody. The right to health, by definition, is more than just about availability of health facilities. It speaks about underlying determinants such as safe, potable water, nutrition, healthy living environment, healthy working environments. It also speaks about systems of health protection, which means we must also be creating a condition or context in all of our communities, in all of our countries, where there is equal opportunity to realize the right to health. And what does that mean? It means that we ought to be concerned about planning, about stewardship, about health resourcing, about what's really important, the economic, social, but also political rights. Because without these rights, if people don't know they have these particular rights, they can't even fight for them, right? But we also need to move, and as a clinician, from a malpractice, very combative, abrasive relationship we have with patients and how they engage with the health system. And why is this important? Because in terms of the various working methods available to me as the UN Special Rapporteur, one of them, of course, is to be available for conversations such as this today, but also produce annual reports for the Human Rights Council, do country visits, and also analyze in context in those different countries why for them specifically they haven't realized the right to health. And it comes down to one thing: health is political. Health is absolutely political. And this is why at the beginning of my tenure, when I was giving the General Assembly, it's almost 5 years ago now, my strategic priorities, I did something very odd that people did not understand, firstly for a medical doctor, and also then for someone who's coming into the human rights system. I said I wanted to adopt an anti-colonial and anti-racist analysis to why the right to health is not being realized. It wasn't enough to just say there's health indicators for polio, measles, children dying under 5, and in most instances you can say we're doing very well. But who isn't doing well, and why aren't they doing well? And so it was important, therefore, with that analysis, to then also bring us forward to what are some of the solutions. And substantive equality became something that I wanted to center my tenure on. And substantive equality is important because for me, it's what restores people's dignity. Because that's what happens when you engage in a health system, even during pandemics. How many people felt so completely unable to get information they required in the language they required to make informed decisions about testing, even before the vaccine came, just having a test done. And how many people could not make informed decisions about what kind of support or intervention that they thought was best for them. They had to balance their economic participation, because they still had to pay rent and put food on the table, and their own health needs. So the ways in which people interact with the public health system has to be dignified. And because we know so much goes wrong, for me it was important to actually just talk about the restoration of dignity, because I'm assuming that some of us at some point have had an experience that wasn't ideal. And so the right to health is interdependent, it's indivisible, and it's foundational. And I'm of course biased because it's my favorite human right, but it does link all of the other human rights together. Without health, we have nothing. We have seen. Can I ask for a door to be open? Sorry, I'm having a hot flush. Sorry, some of the things happen, and it's happening. And so what's important and why the right to health is my favorite right is because when you realize the right to health, a person is also able to participate in the economy, in sport, in cultural activities of their choice. They're able to gain and stay in education. If you're a young girl, we know about period poverty. There's so much that the right to health unlocks when we get it right. But there's also so much that gets violated when we don't get it right. And so here's the political part of today's conversation. We know that there are grounds that are prohibited for discrimination. But in practice, sometimes people do get discriminated against, despite what the law says. And it's often those who are least able to get recourse, or even when they know something has happened, they know that the consequences of trying to get recourse and justice is perhaps even worse than their violation. So people are constantly having to weigh up. And why then the substantive equality is important, because it forces us to speak about power and not look at people and say, these people are having bad health outcomes because they're making bad individual decisions. It's about understanding the systems of power and how they shift and move through a person to determine who gets access to health services, to goods, to quality care, acceptable care, timeous care even. And power and privilege, therefore, has to be understood within the right to health perspective because it leads to advantage or disadvantage. A concept known, and some of you may have come across this, but who is killed versus who's allowed to die? There's a difference. And so you have to understand the social matrix in which people find themselves. I may be standing here now as the UN Special Rapporteur with all of you, but when we all walk out, we are all getting catcalled. We are all experiencing the same abuse that's gendered, right? That's sexist. In another environment, I may be feeling very strong and autonomous and empowered. And a minute later, something else happens and I'm completely feeling disempowered and non-autonomous. So there is a way in which my social positioning also changes and shifts even with me. And so what does that mean for pandemics? What does it mean for leaders? Who is in the room? Who's there to actually have these conversations and have the lived experience not seen as some, story about life and just come and, the kumbaya, but do we actually see people's lived experience as credible enough? Do we see them as credible enough to know and understand their communities and what they need? And so in the context of the pandemic, we know that even at our best, we were never, ever prepared, ever. And a lot of the world is so militarized, even before that and now in terms of security, but we forgot that these artificial borders, viruses do not respect. And so the power imbalances that I've been talking about on sort of community individual level replicate themselves in the higher levels, multilateral systems as well. Where non-transparent decision making got all of us very frustrated. Why can't you just release the vaccine and everyone can just get it done, right? Why are you hoarding the diagnostics? And so the role of the state, the government, I think all of us kind of agree that they have obligations, they have particular responsibilities. But how often do we talk about non-state actors, but specifically business in health? It's almost assumed that they have a perpetual right to profit, make decisions, set up particular schemes around health that exclude even the health practitioners such as ourselves. And one thing about the pandemic, what it showed us is that when decisions are delayed, the impact is felt by those people who are poorer, furthest from health systems, and unfortunately unable to recover as fast as other people in particular class privilege or protected spaces are. And that's why we ought to concern ourselves with research and development, equity around manufacturing and IP registration. We have to consider and especially look at the ways in which policy is developed and changed in an emergency. Who declares an emergency and by when? And who does it affect before it's declared, right? And we can look at many different examples such as Mpox. We even had to fight to get it not called monkeypox, right? Because even language matters. Language can cause stigmatization as well, just as an example. And so coming back to this idea of dignity, what does dignity look like in human rights? Because human rights are already seen as abstract, right? Like they're up there in the sky. How do we make human rights tangible? And now you bring this idea of restoring dignity using the right to health. It is a global imperative and not just a moral one, but it's a political choice to give people back that dignity. It's a choice that people live undignified lives. And so it's a political choice as well to ensure that everyone everywhere can realize their right to health. But it cannot be realized in the context of austerity, in the context of protracted wars, in the ways in which unfair lending practices are happening and taxation is affecting small developing island states, for example, the ways in which unilateral sanctions are being used as a political tool. And so by ignoring health as a human right is political. And we have to, all of us, try to get as many of our own governments to realize and actually recognize and ratify the right to health as a human right. Because that way it gives them particular obligations and gives the rights holders an opportunity to hold them responsible to a particular standard. When health is seen just as for profit, when health is seen as something for those who can afford, it means that, again, the fault lines will always remain in a pandemic, in a non-pandemic. And when we do have a health crisis, it sits and stews and marinates, as I often say, like an abscess. And then we can either intervene early and do what we need, but it's going to depend on us seeing those people first as fully human and worthy of dignity to be able to modify and be agile and resource the kind of responses that are required. So vaccine inequity is, of course, one clear example. At some point, many of us were calling it vaccine apartheid, even. And so it's important, just in closing, and because we're going to have a longer conversation with Dr. Kavanagh, that the right to health relies on public participation. It's not a right that is a privatized right for Congress or for the lower house. Am I saying them correctly? Capitol Hill, right? It's not just a conversation for Capitol Hill. It's a conversation that must be happening in town halls, in communities. But there is a challenge that we are in the moment in the world. And that these processes are becoming more and more closed to civil society, but also to experts who are human rights, who are doing human rights work and standard setting. And so we must, all of us, advocate for a rights-based health policy and prioritize equity and dignity. It's not enough to just prioritize indicators and be happy that the trends are good. What about the inequality within the country affecting particular demographics of people? We ought to be concerned about them as well. And I say this in my country visits all the time. I've been to Luxembourg, Chile, Costa Rica, and Thailand. And all of the ministries of health says, but look at our trends. Everything looks amazing. And I said, you can do well for 90% of the population. But human rights demands that we look at the 10% and be concerned about why they are not thriving. So we must move from just survival to thriving and empower communities to shape health policy and systems. But trust is important, and it is a foundation, because without trust-based and truthful partnerships with government, civil society, and all of us as stakeholders, this process is going to be really difficult. And in the context of stigmatization, criminalization, and discrimination, people are less likely to seek therapeutic relationships or seek care. They are less likely to maintain and stay on treatment, and they are less likely to come back should anything else go on or have complications. And then we are in that cycle of individual people making individual bad decisions, as opposed to what is it about the system that's unprepared. So now imagine in a moment of pandemics when the whole entire population is now putting strain on the public health system, what then happens? And so in closing, I just wanted to say that every human being is entitled to the enjoyment of the highest attainable standard of physical and mental health. I took a shortcut. Thanks for doing the long one, Matt. And creating a society and living in a society that's conducive to a life of dignity. And that requires us to respect autonomy, non-discrimination, ensure meaningful participation, but also demand transparency and accountability for when things go wrong. Things can go wrong in public health. Ambassador will tell you, things go wrong. But what we need is leaders, duty bearers, who are able to explain, regain trust, and then together through that trust-based relationship move forward. And global health must be centered around solidarity, equity, and respect for dignity. And all of these are political. Who gets to be in the room, who doesn't get to be in the room, whose story is seen as credible or not credible, who's seen as an expert and who isn't seen as an expert, all of those things are political, but they ultimately determine where budgets are spent, how they are spent, which conditions are prioritized and which aren't. And so the pandemics gives us a bigger overview of what we know as fractures within public health that maintain and persist. And therefore the work we do as we leave this room today, we must accept that the work we're doing is political, first and foremost. Because once we can accept that, then we can summon the necessary response and might and fight for what awaits us out there. So thank you, Dr. Kavanagh. And thank all of you.
And so we are gonna then have a conversation that builds off of
While I melt.
while you melt. We've opened the doors, so hopefully it will come around.
Let's do this.
It's actually beautiful outside,
Thank
so
you,
we
darling.
could open a window maybe. So we're gonna have a conversation around kind of some of what you just put out onto the table for us. And so first off, let's give her one more round of applause. So thank you, Dr. Sue, for being here. We appreciate it. So I want to start kind of where you at some point dove in, and you said, "Who gets to declare a pandemic?"
Yeah.
And I think this is a very interesting question, right? So we're sitting here in Washington, D.C., where there has just been declared an outbreak of Ebola in the DRC. The World Health Organization has just declared that Mpox is no longer a public health emergency. And I wonder if you could just say more about this idea of who gets to declare a pandemic. You raised the question, but then you didn't answer it. So I'm gonna push you a little bit to answer and tell us, why does this matter? Like what is it that you're trying to get at there?
So it matters because people's humanity matter, and you have to first and foremost see them as deserving of accessible, acceptable quality care, regardless of their state. And often when you're talking about Ebola, you're talking about Mpox, they're affecting people, for example, on the continent of Africa, and it seems far removed from Capitol Hill, Washington, DC. Until a nurse who's European gets Ebola, right? Then suddenly it's a crisis, and now it gets declared an emergency, and all of the resources, research and development, all of the epidemiological ways in which we know response should happen then happens. And so for some people, health and intervention is seen as a right, and it's life-saving and it's important, and of course the right to health believes, in fact, that scientific development and discovery is a human right. It's not even if you discover a vaccine, that discovery must benefit public good. It's not a private process. Why that's important, Matt, is that for the Africa continent, investments in health are done sort of like begrudgingly. And that kind of outlook, it trickles down all the way to the community. And that's why I think often the way in which global solidarity used to look in economic aid also itself at some point was important. But it came in a space where there was already a vacuum created. Why is it that some countries actually can't summon the necessary public health response to meet their own needs, right? And it's that history of racism, extractive capitalism, and everything that happens in these communities. So by the time the Ebola comes, it's one crisis, but they're dealing with so many other crises as well. And why not help them, right? Because you've neglected all of the others. Why would now suddenly, because it's Ebola, you care? It's because you already do not see them as fully human. And that's why for me dignity is important, because it doesn't matter who you are. If I ask you what's dignified care for you today, it's a self-determined thing. For me, dignity looks different as a person who's having a hot flash in front of a whole class, okay? So my idea of dignity looks very different right now than it did yesterday. But for the people who are having Ebola, Mpox, if you ask them what do we need immediately, They will tell you what they need. And often people think there's an English word I'm looking for. So for example, we would often go into communities and say, youth-friendly clinics, you can come to the clinic. Not a pandemic, but I'm just making a point here. And then the clinic would be set up and the services would be there and the nurses would be there. And then people say, but there's no uptake of care. It's because we never asked the young people, why could you not come to the previous clinic in the first place? It's because there was no roads. When it rained, it flooded. There's no street lights, so they are scared to come after sunset or too early in the morning for services before after work, right? So it's not that women in that space don't care about themselves. It's that there's structurally things that they just cannot get over to get to the services. And so then people get fatigued. They say, oh, but we come up with all these programs and then there's no uptake. So it can look like as simple as youth-friendly clinics, or it can be as hectic as pandemic or Mpox or Ebola. And I don't know, the fatigue, it's there. Definitely there's a political fatigue, just period. And a lack of global solidarity. But it requires all of us firstly to see each other fully as human and actually deserving of all of these rights, first and foremost.
So we have an analysis that's going to come out at some point, if we can ever finish it. This is my fault. But that looks at Mpox, right? And Mpox is very interesting because you have this kind of global emergency declared, and then about, kind of 2/3 of the way into that global emergency, all of a sudden there starts being cases popping up all over the DRC, right? And it's different than the Mpox outbreak that's happening in Latin America and in the United States and in Europe. It's a separate outbreak. It's not linked per se. And the official word was, those are unconfirmed cases. Unconfirmed cases. And then the official word was, well, they might be real, but they're all within the Democratic Republic of Congo. Now, the DRC is like far larger. Somebody can correct me, so Google me on this, but I think it's the size of the entirety of Europe. But it's all one country, and therefore things don't cross the border. And so we're in this really interesting moment of transformation of pandemic law, where we've just passed a new pandemic treaty, the international health regulations were just redone. There's been all of this kind of attention to, we failed during COVID, now we need to fix it. Have we?
No.
I'm shocked.
No. No, and I'll tell you what, oh sorry, microphone. And it's simple, it's the politics part of it. And it's the fact that the human rights principles are still devoid as a framework of how this was set up. If you look at the kinds of negotiations that had to go through and the kinds of concessions and some texts that had to come out, absolutely no. We are going to repeat the same mistakes we did with COVID-19. And maybe as humans, we need to just accept that we don't learn from history. Like maybe that's not the point of history. And that history is actually very much the present. And that worries me because there was an opportunity in terms of global governance and institutions in the multilateral system to really, really sit strongly on human rights, because it's one of the frameworks that actually just not gives obligations, but gives responsibilities, but also gives you a way of actually how to fund and move forward. And when things happen, there'll be recourse. It's like a straight, clear line. And yet everyone is running away from it. Maybe it's because it's obligations and it's language of, people are scared of human rights. But that's literally what binds us. If we don't have human rights as people in this room, there's nothing for us to hold each other accountable to.
And I'm gonna just push you a little bit, because I think this is really interesting. It's absolutely true that if you look at the pandemic treaty, there was lots and lots of back and forth and very little conversation around rights, right? They basically do not appear. If they had, what would that have brought? Like, you're the UNSR, your job is to love human rights, so fine, we know that you love human rights, but you're here in Washington, right? Where there is a lot of skepticism around the idea that rights really can do very much, especially in a moment like this. If human rights had been present in, or were present in the pandemic treaty, what do you think that would give us? Like, what would be different about doing that?
I think we would have moved a little bit in terms of the over-influence of the business in health. I think in a lot of rooms, there were just far too many private sector interests and business interests, and not enough community-based leadership and people who have been people's advocates around different health movements. If you think of South Africa as an example, it always takes the work of civil society to get the government to do the right thing. Whether it was the prevention of mother-to-child ARV medication, the program, it took a constitutional court case to make that a reality. And because our constitution is based on human rights as a framework, it meant resourcing, it meant listening to women, getting them to participate in terms of what dignified care in the clinical setting looks like. What do safer communities actually look like? Because then you know that many women were actually getting seroconverted or getting HIV from trigger warning gender-based violence and sexual violence, right? So just focusing on let's prevent HIV for the children, ignoring how their mothers got it in the first place, was doing also an injustice. So it looks at the whole entire continuum in the context of illness and at least the context of people's lives. And so for me, a lot more civil society but advocacy-focused groups would be in the room, because even when governments were failing to give food, again, it took another court judgment to make sure that children who were getting school feeding schemes, those nutritious meals stopped during COVID. It was advocacy of civil society who made sure it continues in many parts of the world. And so that's what would be different. You would have not just the clinical, technical aspect of how do we respond to pandemics, you'd have a whole, what I call health system is a social system. What do we do about nutritious food? What do we do about safe and potable water? What do we do in an event of economic insecurity, right? That's brought on by the next pandemic. How do we restructure a society to be able to be a social system that can withstand with agility, with resilience? Healthcare workers, we still don't know how they managed with the pandemic. They were not in the room, yet they were the first responders, yet they have so much important information and expertise to give, right? So I think for me, it's whose voice was missing, and because it's missing, there's a texture and a nuance there that's missing, and we just have a very good technical document, but technical documents didn't do what they were meant to do then. It's still a good thing that it was passed. I mean, it took it took a lot.
It did.
So we do have to give credit where it's due. It's there, it passed. But there's still a lot of work that has to do where it's grounded in understanding the politics and the impact and disproportionate impact on poor people, marginalized people, and all the discrimination and the things I spoke about.
I like that. And I think the other thing that kind of rights do, right, is, and you kind of alluded to this, right, where there's adjudication, right? There's a claims making process that can happen, et cetera, et cetera. And I wonder if you want to talk about that a little bit, because I think one thing that's very interesting is that in the middle of COVID-19, but in the middle of pretty much every pandemic, we've seen a situation where some countries were getting what they needed and some countries were not. And we kind of chalk that up to, well, that's just international politics. But there has been an effort over the last 50 years of trying to build an international system of law, right? Both of international law, but also of domestic laws that instantiate those rights in a practical way. And so I wonder, as you are UNSR, and as you receive, I know you receive complaints from people all over the world, you receive kind of accusations and claims letters, et cetera. And one of the most interesting things about the kind of international human rights system is that your position has been set up, that there is this recognition of individuals within states, not just states. And so I wonder, how are you seeing opportunities now for courts and law to support this, or are we seeing that courts and law, I mean, we're sitting in Washington, and I have to say my particular view on courts is not particularly strong right now.
I did an amicus brief to the SCOTUS Roe v. Wade,
There
just
you go.
saying. So.
But so do you have, how are you seeing the role of courts and international law in this space of kind of pandemics and making things better? Yeah.
And maybe you saw my notes for when I'm for my SR next year, but there's this idea of the right to health as a justiciable right. And more countries are using that precisely because it doesn't talk about like just health facilities. The other issues of underlying determinants, entitlements to be free from torture, ill treatment, non-consensual medical treatment, but also very clearly speaking about health environments and communities. So people are linking the right to health to many other intersecting advocacy moments. So the climate crisis and the folks in climate and environmental justice. There's a lot that people are able, through the right to health, to make particular claims that they can't solely just going for climate or the right to health environment. And the kinds of complaints that I get are that nuanced and that complicated that sometimes I have to bring in my other colleagues who are other experts in other thematic areas. But sometimes what's really interesting is that because of the anti-colonial, anti-racist approach, it was harder for member states to see what it meant, but now they see it actually works. Because I'm not saying you are bad leaders today because there's a particular issue of access to vaccines today. I'm saying there's a context in which your country politically has had to go through that has determined whether you are low income, middle income, high income, whether you are called Global South, Global North, even though you're Australia, but if we say you are Global South, right, it's like, it's weird, but what do you mean? So there's a context to that. And so it's understanding that to then bring everybody around together to say, if we understand there's a history of how we got here, and we're saying that in this particular region, indigenous peoples in Mapuche, for example, in Chile, they're experiencing worse maternal health outcomes, but during the pandemic, they actually did very well. That's a surprise, right? You're thinking indigenous people, doulas, pandemics, surely that must have been a moment of crisis. But because women are seeking care from other women, there's a way in which dignified care was then determined and actually practiced. The way traditional indigenous interventions were then actually perhaps the only thing available for them, suddenly it made the difference. And so in those allegation letters, I focus less on laying blame, but actually saying, with this particular issue, how do we actually make more stakeholders around the table and talk? In many instances, it's the first time that there's any interministerial, any departmental conversation. It's because of that letter of allegation that I write. And what's been really good is that some countries, for example, Luxembourg, immediately said, do a curriculum, do a module on intersex rights. In Chile, in CSW this year, the ministry said, okay, let's hold a roundtable at the UN and talk about the regression in human rights generally. So the solution-oriented part is very important because it's, of course, I need the resolutions and the Human Rights Council mandate and then the obligation language to respect, fulfill, and protect the right to health. But I think the approach is very important, where it brings people to a point of solution and not just you did this, you did that. Domestic courts are important in terms of accountability. Often it's at the transparency step where patients and or rights holders actually don't understand and don't know why decisions were made. Don't know why a line item fell off, for example. And it's that what's contested, transparency. And states know if you have the information you need, you'll hold them accountable. So they don't want to be held accountable. So the right to health for me has been very key in how I think about accountability. But is this accountability leading to what? For me, it's dignity. And for it to be to dignity, I need to speak to the people and say, what is that look like for you? Because I can't determine for you what dignity is. So that commitment to self-determination for me is very, very important, and being autonomous. And the courts have become a space where a lot of our rights are being taken away. So strategic litigation is something that's really, really important globally. And so I'm doing work now with, hopefully, the idea that one day someone will look at the archives and be able to use the work I'm writing in the way that I'm writing it, as a medical person, not a lawyer, but in a way that advances this idea that one day the courts may be the space where everything is contested. And so what do we do about the right to health if people don't think it's a human right and then don't think that it's a justiciable right, which it is, it's both. But that's where the power lies. It's in getting our governments everywhere to ratify the International Covenant on Economic, Social, and Cultural Rights, and then recognize the right to health as a human right. And I think that will be the piece.
So I want to bring two other pieces, and then I'm going to open it up to folks that are in the room. So the first is, you said language matters. And then you used the word apartheid. So I want you to as someone who grew up under the South African apartheid system, when you use the word apartheid to describe what happened during COVID and vaccines, that's not a mistake. I know you well enough to know. So talk to us about, you were UN Special Rapporteur, brand new UN Special Rapporteur, and COVID hit.
Yeah.
Tell us a bit about what did you see and why are you using the word apartheid? Like, why is that the right term? Because it has a very particular historical meaning, but it also has a very particular legal meaning. And so it's one thing to just say, oh, there was vaccine inequality. And I think that's broadly accepted. But your president also used the word apartheid. And he's also a person who is very intentional about where he uses words. And so why is that the right word for an international human rights leader to be using?
So it's important because it speaks about systems of design. And it was very clear that the hope we had of global solidarity, equity, not even equality, just equity, in how governments, member states were approaching the crisis of COVID as it emerged, that we had misplaced our hopes. Way before even the vaccine became even something that scientifically everyone was just eager to develop, we had to have diagnostics. We had to have personal protective equipment for healthcare workers. I went back to clinical practice to donate my time to maternity wards because I knew the kinds of pressures that would be created. So even before the vaccine, we already knew there was an immediate hoarding and imbalance in just how governments were now embarking on purchasing all of these products. And it's important to look at the whole chain, right, of diagnostics, treatments, vaccine, PPE, within that context of making health private, making it for business. The system was designed that those who had less could not get access to PPE, to diagnostics, to treatments, and it meant literal death. This was not just like, oh, there's no PPE, so we'll just see. It meant literal death for many people. Many of those, of course, were health workers and patients in the maternity wards just because of how proximity and how things were done. And by the time we knew it was a respiratory illness, so much had happened. Calling it apartheid also removes that misinformation that, oh, well, black people didn't want to just go test. Or they didn't just want to go to the ER. We did go to the ER, but the pulse oximeter was not reading the oxygenation in our fingers because of the melanin correctly. So instead of being admitted for supplementary oxygen, we're being discharged home to die in our apartments. And the narrative was, well, so many New Yorkers in the black communities are not getting care. No, they did, but they were discharged, whereas the people who were admitted, right? So even in medicine itself, we also call it medical apartheid. It's like a whole big thing. So there's a way in which the system just, by design, no matter how much will you have, who is allowed to die versus who is killed. That's what that concept is. And that's what vaccine apartheid showed us, that there are those who die, but there are those who are just allowed to, to die and just be killed. And that's the difference. That we're all gonna die one day, Matt. Right? That's a fact. But there are some of us
That's your medical
who
opinion?
are just allowed to just, right? And so it's that experience of course, being a South African and then knowing how economic power and dominance works, how diplomatic power and dominance works. And so when you then had international systems, WHO led at least they tried to set up a whole thing of equitable distribution. They were not really supported in the ways that they should have been. There's different ways in which the multilateral systems and different systems of governance tried to lead us all into some equitable outcome. They failed. Why? Economic and diplomatic dominance of particular member states of the UN. And so even how you see the conversations within the United Nations about which countries has permanent seats in the Security Councils, which countries get to veto what, it's all of it related to this literal asymmetry of power that is actually leading to harm. It's not just an asymmetry of power that's benign, it's leading to harm. So the vaccine apartheid thing is very important, and I think it was important that it was probably South Africans who said it, because there is that experience of knowing what medical systems do, when they're designed to let some die, that it had a real meaning and a seriousness to it.
All right, my last question before I open it up to the room is about war. So we are not only sitting in the middle of a moment where we're talking about, kind of global crises on multiple different scales, but we're also seeing kind of a very different era when it comes to war. And you are in the middle of having to negotiate not only what's going on in Europe, but what's going on in Gaza, what's going on in Congo, and thinking about kind of the variety of different ways that kind of armed groups and states are acting. How do you think about the right to health, which seems like it's so far away from these macro political issues of who gets to occupy what land? How do you see the right to health coming in there, and how do you hold yourself as the special rapporteur in these contexts?
So yeah, I mean, I went from pandemics to different times altogether right now, and I wrote a report called Violence and the Right to Health, and I presented that report to the Human Rights Council and a different thematic focus to the General Assembly. And the focus of that report was that under the prevailing context of violence in the world, we cannot realize the right to health, whether it's interpersonal violence, whether it's structural violence. And with the current multiple crises and wars and protracted war and genocide and all of those, the right to health is inherently impacted, right? Whether it's the weapons of war that is being used on people's bodies and the kinds of injuries they lead to, whether it's, why does it go off when I'm speaking about war? Whether it's the fact that when you do get injured, you don't have enough healthcare workers because they've been abducted or killed or harassed in the hospitals, right? Whether you are in Congo and you are dealing literally with child labor, and those children can never even thrive and they look stunted, but they work and their bodies look like adult bodies because of how much gold and diamonds they've been digging. So there's something about even like the violence of capitalism, and we're calling it extractive capitalism, right? I mean, there isn't a good version of capitalism, but at least if we just focus just on that particular one, where it depletes resources, it thrives on scarcity, and then everyone is at the bottom just scrambling for the bare minimum. And the continuum of what I often call imperialistic violence, the making of empires and the maintenance of the empire, unfortunately demands and creates indignity for many people for that to happen. And war, and you guys are changing your department's name to Department of War. Like, guys, come on, help us here.
I was
like,
not consulted.
Come on, but those are some of the things, and we need to take that seriously, right? Like, if you can literally say that out loud, I mean, it's going to be a tough world. So the economy of the military, the militarized nature of the world and the globe, is something that's very, very problematic. And we always have this, it's not an argument, but it's something that, legal people versus activists like me, I say, no one is illegal. Like, you can't be born on planet Earth and be illegal. Like, you are a human, you are here, right? Being human can be illegal. So this language, when I say language matters, illegal immigrants, you guys call people from New Orleans migrants when they had the Katrina, right? So that's an example of violence. That's an example of violence, but it's happening within a country that's rich, that has all of the resources, but because of who Katrina affected, the response was what it was. And so the violence of war, but violence making, just as a way of society, the right to health cannot be realized in that context. And that's what I've been sort of trying to wind out my mandate and trying to think of ways in which the right to health can be a space for resistance, resilience, and joy making. Because I myself am feeling very sick and tired and drained from like just having to respond and see firsthand all of the different things. And we talk about the doctors in Syria and the Myanmar border, all of the different struggles that they're going through. So I've focused on health and care workers this year because I wanted to elevate the work they do as human rights defenders. Because of war and how the right to health is impacted, we understand journalists and media freedom. But do we understand how much and how far healthcare workers are being pushed? And do we have enough advocacy networks and support for them to be able to continue to do what they do? Because they're the oath takers. They are not the last to leave, they won't leave, period. So how do we then support them in that context of knowing that no matter the reason for the war, there are people we know who are not gonna leave, and how do we then support them to do what they can do, which is, promote and provide quality health for people. So the idea of war and violence for me is something that has really, it has taken a lot, but I think it has brought a lot as well in terms of community making, and I think it's important from a right to health, sometimes not about the tablet, sometimes about creating a community of practice that's new and understanding that's new, and hopefully it will blossom and find legs somewhere in the future.
May it be so. All right, so we have a bit of time. What do you all want to ask Dr. T? So I see a hand there. We'll take a couple. So people who have a few different thoughts, put up your hands, and then we'll give her a moment.
Thanks so much. First, Dr. Muckleton, we all need to thank you for the work that you do.
Thank you. Thank you.
You may not know from South Africa, but everyone in this room will know the Princess Bride, and there's an ironic line in the Princess Bride from a torturer and murderer who says, if you haven't got your health, then you haven't got any. So you might want to use that reference. The main question I really wanted to ask you about builds on this question of the distinction between law and politics. Most of the people in this room probably haven't taken Latin. It's a fundamental maxim that ubi jus sibi remedium. In other words, if you have a right, you have a remedy. And the problem, even with the progressive realization of human rights, is that we don't have a remedy when states don't progressively realize the rights within their capacity. That's the fundamental problem. It's one thing to call it out, it's another thing to say this is a question of law, when the underlying international system of state sovereignty and national self-interest is what rules the world. So what would you say to these young people about getting off their asses and protesting, right? To try to change the world so that human rights are actually a right with a remedy, which then requires undermining the fundamental basis of our entire world of national self-interest and state sovereignty, because then states can't keep the vaccine for themselves. They can't refuse to provide things that other people need more.
I said we were going to take several,
Can I just
but
do
I
that
don't think
one?
we can.
No.
So thank you for
Can I do
that.
that?
That excellent. Please go ahead.
And it's because the allure of the empire. So you think if you remain proximal to power in the system, and it will somehow rub off and you will get some protection. And what you're saying is life teaches you that there is no such a thing. You can be as proximal as you can to power, but when the time comes, it always chooses itself. And so that's why I believe so much in community work and community advocating and organizing, because it's the only way that the majority of the people can actually get their voices heard. But if we are not cross-movement building, it's always just those ones who are about the vaccines. Then it's just the siloed approach for maternal health. Then it's just TB. Then it's just HIV. But if we are all for all of our dignity and we say not on my watch, regardless of what that person is going through right now. They may be experiencing homelessness. There may be a person who needs a drug reversal. It's not for me to judge what the people need or what the persons need or what vulnerable situation they are in. And I think it's that commitment to each other and our own humanity that's missing, because there will always be something that makes us different. There will always be a context that's worse or better, but I think we are just fundamentally disconnected from our own connection as humans. And that's how systems of oppression and power work. It's first by disconnecting you from your lands, from your culture, from your tradition, from your language, and before you know it, we have nothing to cling on together. And I'm always in sneakers, even now, precisely for that reason. If there's a need to protest, I'm ready. So, you know, I'm ready. And sometimes I start my class and I say, you know, everyone must write something that they will stand for, like no matter who says what, you will stand for that principle regardless. And they all write it down, and I said, fine, let's just take a few steps down to Capitol Hill, and you say as a one-man protest, go and hold that sign up. And they get terrified. So we are losing the recipes. We are losing the recipes. And so who's gonna give this intergenerational, who's doing the intergenerational work of advocacy and activism and community building? Communities building doesn't just happen, but we've lost the recipes. Unfortunately, that's my answer, is that we've lost the recipes.
And we all need sneakers.
And we all need sneakers. Be ready.
All right, I see two here, one and then two.
Thank you for your really thoughtful conversation. You kind of have already alluded to your answer here, but I really loved what you said about prioritizing equity. And I feel very confident that everyone in this room believes in the equality of every person and that there is a right to health. But outside of this classroom, outside this campus, that isn't always an assumption that we can make, that everyone understands there is a right to health. So what are the tactics that you've used for getting uncaring people sometimes to care, whether that be at the individual, stakeholder, or partner-nation level?
All right, and sorry, say who you are.
Oh, hi, I'm Gretchen. I'm an alumni. Thanks for inviting me, Dr. Kavanaugh.
I won't forget.
My name is Martha, and I'm a student, but I'm also from Africa. And I wanted to ask a question about the human rights and civil rights fights that we've had to endure over the years. I think you mentioned apartheid, colonialism, neocol, all the systems of oppression against, I think you described it as a global north that doesn't recognize human rights in their healthcare, right? So, case in point, the withdrawal of USAID and impact of PEPFAR, the millions of people who are being impacted by that are nowhere able to come and wear sneakers here in the United States, never mind going to a judicial system to fight for themselves. My question is, why can't we, not that it's futile, this progressive realization of human rights, but why can't we take it out of the political system and maybe use it in a language that is recognized by the global north, like trade? You know, I'm inspired by non-proliferation agreements where there's actually accountability and stuff like that. So why can't we take it out of politics and maybe attach it to something that can actually benefit people? Thanks.
All right, so you've got two, one on kind of how do you get people to care, and another one on kind of are we in the right system here, right? Is there a move out of politics or even a move out of rights, I almost hear Martha saying, but that might get us into a different framework that might succeed differently.
So I think it's important, for example, to recognize that the World Trade Organization already exists, right? For trade and all of those agreements. And in fact, why we insisted on calling it vaccine apartheid is that there were those frameworks that could be amended, modified for a period, agreed, to allow for equal and equitable access. It wasn't even a perpetual thing around like IPs forever, we doing the, no. It had timelines, right? So no, it already failed, taking it out of politics into economy. But it's the same thing, right? I think it's a false separation. It's all political, whether it's the economy, whether it's social, whether it's civil, it's all of it political. And I think the trap is to think that you can sanitize it by making it apolitical, because our lives are already political. Where you are born is already political because it exactly sets you up for either dying or being allowed to die. That's a political thing. If you think about economy and the redlining when that happens, the fact that research and development for women's health is still basically, okay, let's put it this way. The research for the blue pill took less than 7 years. because doctors were reporting the side effects that their male patients were talking about when they were being given this treatment for their heart condition. And the system said, fabulous. This is a good thing. Right? And the system is, and I call it the boys' club, the medical fraternity, because it is. And within 7 years, they had gone from, oh my gosh, there's this side effect for heart treatment, to erectile dysfunction is being cured and men are having good, pleasurable experiences. Within 7 years, the FDA had approved all of that, and there was money making in the market. Pap smear, intrauterine device, women are still fighting to even get anesthesia for these treatments and for these operations, right? Men don't have to get a motivation why they need a anesthesia to get a vasectomy. We must still motivate why we need all of the things we need for endometriosis. So you can't remove the politics, the misogyny, the sexism from economy of health and profit making. It's all related, in a nutshell. The second question is harder, which was the first. How do you speak to people on the other side? So that differs from my own positionality and how empowered I feel, to be honest with you. Some days I have no time to speak to people who are against my own humanity. So there are things that I will not discuss, right? I will not sit and perform why, as a black woman, I must be a person and I'm human. They're just like days where I'm just not having that conversation. But there are days where I know that when I don't have that conversation or push back on some of that harmful rhetoric in a particular setting, where I have the power and authority and some maybe protection because I can say I'm a doctor, or because I can say I'm the UN Special Rapporteur, you can't argue with me. I have to use that power then, you know? But sometimes it's not always that you can and you feel that you can. Sometimes it's not safe to take on people who are against your own beliefs. But I do think cross-movement building takes time and takes effort, and that's why one of the big things I'm into now is this feminist grant making, right? Where we need to understand that the political systems we need to change were not designed overnight. So it's not gonna take one feminist in the UN saying we need equality, we need fairness, we need research and development for women's treatment, for all of that to just change. So what does it look like then to talk to the people on the other side when you don't have resources, when it always will take civil society to try and cross the bridge? So for me, it's also about resourcing. How do we resource movements and realize that that work is actually very hard work? It's some of the hardest work that you can do, is try to convince and keep seeing the humanity of the other person when everything about who they are and what they do is completely degrading of who you are. And it's a very tough thing to keep doing. And we don't take enough in terms of mental health in this space, in this work. It takes a toll, especially when you are people who are embodying the characteristics of the very thing you are trying to change. So every day you've been triggered, but you know that you have to do good, you have to be better to try and change the system. So it's a lot, But it's possible, but it takes a lot of organizing and resourcing.
Other questions, thoughts? Silences. Can Sanjana get to the middle? That's the question.
Well, track and field.
Hi, my name is Kayla, and I'm currently an undergraduate student studying the intersection of global health and like science, technology, and international affairs. And my question is with regards to your report on sexual and reproductive health rights during the COVID-19 pandemic. In the report, I specifically took note of one of your recommendations of the idea and practice of decolonizing aid. So my question to you is, what does that transition for LMICs look like from, moving from dependency on donor aid to country ownership and health system strengthening with the preservation of human rights at the forefront of that transition?
So I think we have to see health aid as part of reparations. Why is it needed in the first place? And on a national level, we have to talk about maladministration and corruption, which is not an Africa government thing. All governments are corrupt and there's maladministration. But in health specifically, it's one of the highest levels of inappropriate expenditure, for example. Many governments actually, and I'll make an example of my country because they're not gonna get upset, but for example, South Africa will send back 250 million rands of unspent money back to treasury every year in health, and yet people are queuing for 4 or 5 hours before 8 a.m. just to get their antihypertensive medication. So there is something to be said about national context and holding duty bearers accountable there for the kinds of, or the lack of foresight in building internal resilience, but also not just increasing national expenditure on health, because even if you look at what they spend, they still don't get the health outcomes desired anyway. So it's not necessarily only always about increasing the money. It's actually having internal capacity and good stewardship to actually do the required things. What's interesting about global solidarity, it's both economic and technical. So a lot of the global health aid came with both technical support and economic, which is money. The technical part of it was frustrating for many people because what we call now the parachute PhD. You come to the Global South, MPH, you spend 2 weeks in South Africa, you spend 6 weeks in Serengeti, you come back to DC and you are the expert. And you get to write the documents that must now transform my life in Congo, in wherever. And so that disconnect also worsens the progressive realization, worsens the ability for health systems to actually respond to what people need. That example about contraception, yes, it's needed, but if they can't even get there, how will we? So it means we need to speak to the ministry in infrastructure and hold them accountable for why there isn't, even connectivity. Because even I think that reporter spoke about digital health and innovation and how it was used, but it was limited because some people just do not have data and access to what they need. So COVID showed us that also the line items that fall away when people have to shift budgets, it's always sexual and reproductive health rights. And so that's what happened with COVID. And then the issue of interpersonal violence, people stayed home, children were being abused, the intimate partner violence rose up, and then people could not escape the home to then get the care or to even say something to someone. And for many people, work and school were their only moment of peace. And so when you then say lockdown, everybody go home, what does it actually mean for some people, right, who are already ostracized by their family for being gender non-conformative, for example? So yeah, there's a lot about COVID and SRHR. I think nationally there has to be more responsibility, and globally we need to look at support to other member states as reparations and not just as aid. Reparation is important. The word is very political by choice. So it's not aid, it's not nice to have, it's reparation.
So last question for you, and then we'll take a break. Where do you see the international, it's a nice, a small question too. Where do you see the international human rights infrastructure institutions going? You've just spent the last several years, and you're coming, over the next 12 months, you'll wrap up your tenure. But you saw us through a pandemic, and what we see unquestionably around the world is rising populism, rising nationalism. Just like there's conversations going on right now about whether the UNGA will be moved to Geneva because people are getting denied access to visas to be able to come. The international human rights system is under pressure that certainly in my lifetime it has never been under. Where do you see things going? Are you deeply pessimistic? Are you somewhat optimistic? Are you wildly optimistic? Where do you think things are going?
I'm deeply exhausted, but very optimistic still. I think this is the last frontier. Like, we are now fighting for our lives. And I want to say two things. One is that, and I still don't know the answer, but I think I know what my heart wants, is that we do have people who have a lot of economic, diplomatic, military power, doing a lot of threatening things. And we are at the cusp of something breaking, but we don't know what's going to emerge. And so it's in that restlessness that we now sit. And so my optimism is that human rights for me is ultimately what will remain. And we have to protect the mechanisms, the institutions, because they are being deliberately and intentionally made to look weak. They are not weak. They are being made to look weak. And so when you think of the ICJ, when you think of the Human Rights Council, when you think of this example now of the General Assembly, there are agreements that if you are going to be a host country for the United Nations, which is for everybody, it's the United Nations is for all of us, there are courtesies that are just basic. And so now we are in a place where we are eroding even the very basics of just like the bare minimum. And I'm also not sure what we are unlocking. Like what new level of just disorder are we unlocking? And so the restlessness comes from that, not knowing what's emerging, but very clear that we are in something, but also knowing that these human rights systems will withstand the pressure. Is the pressure nice? No. Do we wish we were not under so much pressure? Yes. Are we tired completely? Absolutely. But we have to keep the fight, because for many people, for many rights holders, those institutions are all they have. And you can imagine the kinds of complaints and submissions I've read throughout these 6 years, to know that we don't have a choice but to defend human rights as principles, period, but the institutions themselves. And they may be frustrating. I mean, I'm a UN proximal person, and they frustrate me too, and I've told them as much. And so it's not like, it's a secret that there is a crisis as well. And I do think we need to think very clearly about the kind of leaders who will take us to the next phase of what this thing that's about to emerge is, because I'm not convinced that the leaders we have, and you can pick any country, any multilateral system, anything, that they are the ones that we need for the future we want.
Well, on that note, please join me in thanking Dr. Mofokeng. You are all welcome to come on out and enjoy a little bit of cheese and crackers outside. Students, we will reconvene at 2 o'clock right here. So students in my class, we will reconvene for a closed door session. So thanks, take a break.
Thank you.